Hi, this is Dr. Acker, and this is the lecture on syncope for Nurse 525. Syncope is such a vast topic that for this course, we're just going to touch on the highlights, as you'll learn more about syncope, the management and treatment of your patient, as you progress further in the program in your adult courses. This is really just meant to be an overview of it for you. So syncope is the temporary loss of consciousness that's accompanied by fainting, loss of muscle tone, and possibly brief tonic contractions of the face, extremities, and trunk. As we look at the etiology of syncope, there are numerous reasons that this may occur. For the purpose of this lecture, we're going to focus on 6 of the top reasons that we may see in a primary care practice. So beginning with hypotension. Postural or orthostatic hypotension could certainly cause syncope, and this is caused mostly by dehydration or an autonomic insufficiency or even medication. If you see people on polypharmacy that have multiple meds or take narcotics, it is not uncommon with medication to see syncope. Another thing to think about are those patients that are on hypertensive medications that lose weight, whether it be surgery or intentional. If their hypertension medication is not managed appropriately, it will lower their blood pressure too much, and then you'll have a syncopal episode. Also, when we look at hypotension, you want to remember that systemic hypotension can lead to a brief cerebral ischemia, which causes loss of function. Also, impaired vasoconstriction results in hypotension with decreased cerebral perfusion. This would include vasovagal or carotid sinus syncope. The pathophysiology that's related to the reflex-mediated vasomotor instability, decreased cardiac output or blood flow obstruction, metabolic disturbances such as hypoglycemia, hypoxia, or hyperventilation, or even neurologic events such as seizures and cerebral vascular diseases can also manifest itself in the form of hypotension. So pay particular note to that if you see a patient with syncope. Always make sure you're checking their orthostatic blood pressures. When we look at vasovagal, that's a pretty common one that everyone should be familiar with. Vasovagal is usually the cause of a simple syncopal episode, and it's usually triggered by an event such as fear, pain, excitement, or even extended periods of standing still without bending the knees, especially when you're in a warm environment and becoming overheated. When we look at children, we want to pay particular note to the asthmatic children because they can have what's called cough syncope. This is predominantly caused by those asthmatic patients that just can't catch their breath during a cough and they end up vagaling down. Now, cardiogenic syncope is usually caused by a disturbance of rhythm, conduction, or even hemodynamics. Really, when you're looking at the rhythms, think about those patients in AFib, or a flutter, even a stable V-tach, or a non-symptomatic V-tach at the moment before they become symptomatic. These are people that are really having a conduction issue, therefore their oxygenation is going to be impaired. As we look at psychiatric reasons, I think we often leave this out of many of the etiologies for a lot of common complaints from our patients, but it's a pretty real event. People with anxiety, depression, or even conversion disorder will often have these attacks in which they hypoventilate, they just become so disoriented, and due to lack of oxygen, they actually will have a syncopal episode. Now, when we look at neurologic disorders that cause syncope, this is pretty rare. This would really be a sign of a more significant neurologic problem if that was the cause. Such as TIAs or even migraines, and that would just need further workup. So moving on, as we talk about risk factors, I also want to talk about the incidence and demographics that you may see with these patients. 30% of adults are going to experience at least one episode of syncope, and it accounts for about 3% of all emergency room visits. It's very common in young women and is often associated with stress or pain. Syncopal episodes do occur in children. 10 to 15% of all adolescents will experience this, but it is pretty uncommon to have a syncopal episode before the age of 10 to 12. So when we look at the risk factors, you think about these cardiac disease, as we talked about, um, with sixth sinus syndrome, with cardiac dysrhythmias, a conduction issue, such as a block. Those are just common risk factors. Diabetes, also, when you think about hypoglycemia, that can certainly cause a syncopal episode. Asthma, we sort of already talked about with the cough in children, but can happen with hyperventilation or not being able to catch your breath in adults as well. An interesting risk factor is those that have a family history of sudden death. So while it may not always be genetically related, it does put you at a higher risk because we don't test for this typically in patients. There's not really a test for syncope, nor is there for sudden cardiac death. We're not doing echoes and MRIs and CTs on every patient that walks in. So, these are just some things to think about, that may be a sign that's preceding a sudden death episode that we may be able to catch. So if we look at the presenting patient, this is the patient that will come in complaining of a syncopal episode that's hopefully witnessed but may not be. And it's going to be really important during our assessment that we do a really thorough history. We want to know details that include the symptoms before and after the event. Were they changing positions? Were they standing for a long time? Did they have lightheadedness or diaphoresis, nausea, or did they experience a visual change before the event? How long were they unconscious? Was there a seizure involved? Did they fall or injure their head during that? You also want to make sure that you do an oral exam, as oftentimes if they have a syncopal episode and fall, they bite their tongue. Do they have confusion or drowsiness after the event? This may lead you to believe that they're having a seizure. Are there any cardiac or neurologic symptoms such as chest pain, palpitations, headaches, aphasia, any kind of signs of a stroke? Did they have incontinence of the bowel and bladder? Again, speaking to a seizure. You also want to review their past medical history. Any medications such as vasodilators, beta blockers, diuretics, or anticholinergics can also be a leading cause to syncopal episodes. When you're looking at medications, you want to see, did you change your medication recently? And definitely you want to interview any family or witnesses that were there to try to give you a better picture, because most patients that have a syncopal episode don't really remember what led to it, caused it, or how they responded right after. When you're doing your physical exam, obviously you're going to take your vital signs, but you want to make sure to do those orthostatic blood pressures to make sure that there's not a drop. You want to do a very thorough cardiovascular exam. You want to monitor for any arrhythmias, murmurs. Very important for cardiomegaly, you want to see if there's a displaced PMI. Are there bruits or differences in blood pressures between both arms when you're taking those orthostatic pressures? During your neurologic exam, you just want to look for focal deficits. Now, diagnostic studies, you will be led by the presentation of your patient, by the history of the syncopal episode, to see exactly what's appropriate, as all of these will not be appropriate for every patient. But a simple EKG to rule out an arrhythmia or cardiac disease that you may be able to find, chest x-rays if it was associated with a cough or a vagal incident. You want to rule out anemia or metabolic abnormalities with a CBC or electrolyte, thyroid function test, or even a fasting blood glucose to see if they are hypoglycemic or maybe diabetic that we didn't know about. If it is a woman that has a syncopal episode and in their childbearing years, you definitely want to do a pregnancy test. You can also do an echo on the patient to helpfully rule out any kind of valvular disease, particularly if there's a murmur involved. You can do a stress test or even a Holter monitor if they have repeated episodes of syncope. You want to be able to rule out an arrhythmia, and the best way with that would be to have them wear a Holter or an event monitor. If you believe it's orthostatic, you can also do a tilt table for them. You can do EP studies, brain imaging like a CT or MRI, or you can also do a carotid Doppler if they have bruits to sort of rule out any kind of cerebral insufficiency that you may see in a patient. Now, when we are looking at differential diagnosis, obviously with syncope being so vast, you're going to be able to go in any direction. But the ones I really want you to focus on for this class would be the orthostatic hypotension that we've already discussed, a drug reaction, or over-medication, or not adjusting hypertensive medications as appropriate, and then also sick-sinus syndrome, which would be your cardiac issue. And we'll talk more about that probably at a later date. I'm sorry for that ring on my phone. I am on call at the moment, and I'm trying to record this before I have to go into the hospital, so I apologize for that. As we look further into the management and treatment, again, you are going to learn more about that later. One thing I did want to talk about, when you talk about prevention and screening with your patient, make sure that there's adequate hydration. Oftentimes dehydration is the leading cause of syncope, and so just make sure that your patient's adequately hydrated. Now, as we look at special populations, pay special attention to the elderly and the pregnant. With geriatric patients, you're going to see an increased risk secondary to the comorbidities of polypharmacy, autonomic neuropathy, and a dehydration due to decreased fluid intake that you will see in the elderly. And when looking at a pregnant woman, especially in the third trimester, it's not uncommon for them to have a syncopal episode. Due to the aorta being compressed by the enlarged uterus in the supine position. So you never want your pregnant woman to lay flat on her back with nothing under her knees because the uterus actually does compress that aorta and obviously will decrease the blood flow oxygen level, and then they'll have a syncope. So this is the patient that we quote bump. We put a little roll under their left side, or we have pillows under their legs. So this was really just a quick